Hi, I'm Karol Watson. I'm a professor of cardiology at UCLA Medical Center. I run the preventive cardiology program. I'm a lipidologist by training. I am so excited to be able to talk to Dr. Andrew Bellinger today about the blockbuster results from the Verve 101 trial. Dr. Bellinger, this is a new era in lipid management. We've never seen this before. Can you just really quickly tell us what you did?
So, we were struck by the challenges that patients face today with the chronic care model. We asked them to take daily pills or intermittent injections to manage their atherosclerotic cardiovascular disease for decades. And the reality is that very few patients actually succeed in doing that. So we asked, could we develop a one-time gene editing therapy that could mimic naturally occurring protective mutations in the liver to lower LDL cholesterol and thereby reduce their future risk of heart attacks and death. And we've been working on that for the last 5 years at Verve, and today we're able to report the first results, really first in world result for in vivo base editing of the liver to achieve a clinical effect, in this case, lower LDL cholesterol.
That was groundbreaking. We've never seen this before. And what we learned was proof of principle. You can get LDL lowering at the 2 highest doses with gene editing. Now, gene editing, that scares people. We're talking about a very morbid disease, but we're also talking about a disease for which there are other evidence-based therapies. So it makes me ask the question, how did you decide to go after this disease first rather than a disease that we really have nothing else to treat, like sickle cell disease?
Right. Well, heterozygous familial hypercholesterolemia, which is the disease of the patients in this trial, is a very serious and morbid condition. Patients develop heart attacks typically in their 30s, 40s, and 50s, as you well know. And we, despite those existing treatment options that you mentioned, we actually don't do a very good job of treating them today. Most patients, only about 22% of patients in the U.S. Achieve treatment goals today. So we felt like the unmet need is underappreciated, actually, in atherosclerotic cardiovascular disease and the familial hypercholesterolemias in particular. Now, you raised the point about kind of the permanence of gene editing as a potentially scary aspect, and that's certainly real. The way we think about it is that, our patients with cardiovascular disease are very used to signing up for permanent, irreversible procedures. An example would be a stent, or bypass surgery, or implantable, ICD. And this is actually very similar to that in a lot of ways. It's a permanent, irreversible procedure for long-term health. And the way we think about it is kind of less like a drug and more like molecular surgery on the liver. We're making a single base pair change in the DNA in the liver to treat their hyperlipidemia, their high cholesterol. And we believe that we can do that safely by only making one change in their DNA.
How confident are you that there will not be off-target effects or other unanticipated effects once you start manipulating the genome?
Yeah. The way I think about safety for this kind of therapy, it really breaks down into 3 buckets. There's the acute infusion-related safety.
Short-term.
Short-term. There's the, is the edit that you're making a safe edit? And in this case, PCSK9 is a gene that we feel very comfortable editing. And that's because of the human genetics, which say that people who lack this gene completely And they're walking around. Actually, 1 in 40 African Americans has a partial deficiency of this gene.
So they have a loss of function.
They have a loss of function of this gene.
But they don't have complete absence.
Yeah, but there have been a number of analyses, and there are quite a few patients who have complete absence of this protein, and they are walking around healthy with no deleterious, no bad consequences. And second, with this particular target, we now have a fair bit of pharmacologic evidence that you can lower PCSK9 for long periods of time from both the monoclonal antibodies that have been developed and the inclisiran that was approved a few years ago. So there's a pretty large safety data set to say that turning this gene off in the liver will be safe. And then the last bucket is off-target editing, which is, are you making an edit somewhere else in the DNA? And for that, that's actually where we as a company spend the vast majority of our effort.
That makes sense.
Is demonstrating that we are making the one edit we want to make and really no other edits elsewhere in the DNA. And a couple things are important about that. We chose to use a lipid nanoparticle to deliver this. And the reason for that is that unlike a lot of the gene therapies that have been developed that use viruses,
retroviruses,
the lipid nanoparticle is only in the body for a few days, and it only delivers the editor for a few days. So the exposure to editing is very brief, unlike with a lot of viral approaches where you can have edits happening for a long time. The second was a choice of base editing. So base editing is a second generation CRISPR technology. It uses the first generation CRISPR-Cas9 molecule, which is often described as molecular scissors, but it takes away the scissor function, so it can't cut the DNA anymore. And it adds a portion of the protein that can make single base pair changes in the DNA. So it uses the GPS of Cas9, but can only make a single base pair change. And so that gives us a lot of comfort that we're not actually cutting the DNA and creating breaks that might cause what are called structural variants or translocations. We're just making an A to G change. So even if we were to make an A to G change somewhere else, that would be very unlikely to have a clinical consequence. And then lastly, we experimentally evaluate this extensively to try to evaluate for the risk of whether an off-target edit could happen somewhere else. And that includes really deep sequencing of cells, human cells treated with VERVE-101. It includes whole genome sequencing experiments and includes a lot of assessments for those structural variants. So I actually feel very confident that the risk of a deleterious off-target edit with VERVE-101 is very low, and certainly much lower than the risk that these patients face today from their heart disease, which is very significant.
Okay. What is the longest follow-up you have currently?
In humans, it's 6 months, 6 months to a year. So the first patient was dosed in July of 2022. And we've been following them for a little over a year. And we have, in one of the patients in the higher dose cohorts that was treated this past spring, we have 6 months of durability showing that their LDL levels came down by 55%.
And it's remained
And it's
down.
stayed down through the data cut in October.
How long will you need to follow this patient until you're sure this is safe?
Yeah. Well, I think from a durability standpoint, the non-human primate data that we have, so we have follow-up out to 2.5 years and beyond. So we're pretty confident that the effect is likely to be durable because that's a duration that's long enough where we've actually already turned over the liver several times. On the safety side, I think the FDA and the European regulators recommend 15-year follow-up for any patients in a gene editing trial or a gene therapy trial. And so we are in the process of at the beginning stages of that. Mm-hmm. I don't think it's going to take 15 years to get a good sense of whether the risk of this is high or not. I think that will likely come more when we dose more patients. And that is the next step, is to begin expanding the trial to enroll more patients so we can more completely evaluate the safety.
That was going to be my next question. So the first patients you enrolled were very high-risk patients. Will the remainder of the patients you enroll be as high risk? Will you start lower risk enrollment? What do you plan?
Yeah, I mean, we felt this was a new modality, as you highlighted, and so we felt like it was appropriate to enroll very advanced patients, severe advanced patients, and there was some FDA guidance that indicated that human genome editing trials, first-in-human trials, should enroll high-risk patients. But now that we have proof of concept that we can base edit the liver, we can lower LDL cholesterol effectively, we do expect that the risk profile will come down. But as you know, patients with heterozygous FH live their entire life at elevated risk of these events. So I don't think that risk will go to zero, but we do expect that we'll be enrolling a more population representative population of heterozygous FH.
So they will all be heterozygous FH. We will not expand to general hyperlipidemic populations, high-risk ASCVD risk?
Not right away. I think our next studies will be in heterozygous FH. We do ultimately envision that there is a potential to expand into patients who are at very high risk lifetime of cardiovascular disease but don't have a genetic form of hypercholesterolemia. We think it's really just a staged approach of expanding the population.
That makes sense. Dr. Bellinger, this is fascinating work. Thank you so much for discussing with me. I really do look forward to following these results and seeing what the new future of lipid management looks like.
Thank you.